Continuing with our series, looking at anatomy in relation to specific motions, such that the motions become the center point of our network of meaning or our semantic network when looking at anatomy or when considering anatomy. Now we're looking at shoulder extension this time. And as we have already done in looking at scapular motion and shoulder flexion, we want to note that we're going to be almost extra general with respect to the particular pieces of anatomy that we're looking at here, because when you're dealing with a shoulder, because it's the shoulder girdle, or some people say it's called the shoulder complex because it's complex, or when you're looking at the manner in which the multiple joints that would comprise arm or shoulder motion or scapular motion, all of them have a relationship with one another that happens to be important. So when you're looking at the shoulder, you tend to look at it generally, identify specific problems within it or within the region and deal with them, but you still want to check everything. So also, when identifying a problem, if you're considering the neurovascular bundle within the shoulder, because of the location of the neurovascular bundle and all of the branches, if you deal with the motions, you're almost always going to accurately deal with any form of mechanical interference with their neurovascular bundle, be it the nerve, the artery, the vein, or the lymphatics, because you have close relationships with the cervical column, with the scalene muscles, with the clavicle, with the axilla, and with the pectoral tissues in general, as well if you're looking at some of the posterior tissues, with how the scapula happens to be slung from the body primarily by muscles, as well as the acromioclavicular joint, and then by proxy, the sternoclavicular joint. So you've got a lot of connections here that mean that even though we're going to purposely talk about shoulder extension, it is always important to check the shoulder girdle in a fairly full way. So you want a set of movements when you're assessing and treating that will allow you to check into all of these regions that we're talking about, and we'll make that clear as we go through, or as clear as we can in this particular forum, without showing particular assessment or treatment methods, such that there's a general understanding of how to look at this, even though we're speaking specifically about shoulder extension. So our main objectives: a specific discussion of what shoulder extension is, the planes and the axes, general discussion of the muscles that extend the shoulder, a very general discussions of the nerves that supply the muscles that extend the shoulder, a very general discussion of the vascular supply, and then a general discussion of the areas to assess and treat should shoulder extension issues be suspected or reported. Now, before we do this, one of the things that I want to note is that when we're looking at the axial region, so the head, the neck, the thorax, the abdomen, the lumbar region, and the pelvic region, we were adding in organs and particular physiological oversight or concepts. We're going to not do much of that in the appendicular region, so in the appendages, on account of the fact that the network of meaning gets a little bit funny, or sorry, the semantic network gets a little bit funny. So if I'm speaking about something like mechanotransduction, when speaking about shoulder extension, then it may get a little bit fuzzy. So the useful thing to do would be go and look at other physiological topics, generally speaking, but within the overarching project that we're doing here, those things will be touched on, those things will be discussed, but very briefly and not necessarily on purpose. Whereas when we're talking about the axial region, we spoke specifically about organs and some functions. So with respect to our quick overview of planes, the sagittal plane is a 50% cut left to right, with the horizontal or transverse plane being a 50% cut top to bottom, the frontal or coronal plane being a 50% cut back to front. In this case, extension occurs in the sagittal plane about a transverse axis or a horizontal axis, so the axes are perpendicular to the plane. Now, because it's about an axis, right, so shoulder extension or movement of the arm, it won't show up on the screen properly, but essentially movement, if you're in the anatomical position, so palms up, arms at the side, the arm just moves backwards. So, maybe if I raise it up there, it's kind of like it's going back that way. It's going towards the posterior surface of the body. That would be considered shoulder extension. Now, because it's in the sagittal plane about the transverse axis, technically it is a rotational motion, but we call it extension to avoid the confusion with rotation in the horizontal or transverse plane about the vertical axis. That's the common term or the common location and motion where rotation is used. But in this case, we're using extension, even though it technically is, because it's about an axis, a rotation. Now that rotation is essentially occurring not necessarily on a clear-cut axis, but it is the still glenoid with the moving head of the humerus, right? So that is the motion that is occurring. There's no clear axis when you look at the joint because it's multiplanar and multi-axial. However, because of the muscles involved and how they attach to the humerus, they generate the motion about that multiplanar and multi-axial joint in the still glenoid and the moving humerus. The muscles, when we're talking about extension, we're talking about the posterior fibers of the deltoid, the latissimus dorsi, and the teres major. And that is primarily because of how those muscles come from the body and attach, or come from their distal attachments, or maybe even their proximal attachments, because at least in the case of the teres major and the latissimus dorsi, the proximal attachment could be considered either the scapula in the teres major or the lumbar column or the thoracolumbar fascia in the latissimus dorsi, with the distal attachment being the humerus itself. So either way, that those terms can be a little bit funny, but because of the way they come from the body to the humerus, they have the ability to pull the humerus in a posterior fashion, especially when they do so together. Now, in the case of the teres major, the scapula would have to be fixed to do so. So if somehow the medial border of the scapula was not fixed, if the rhomboids on the middle trapezius were not activated in any way, when the teres major shortened, it would actually essentially bring the scapula somewhat towards the humerus. But generally speaking, in order to create shoulder extension, there's going to be a bunch of co-contractions. So the scapula would generally end up being fairly stable and steady, and it's going to pull the humerus posterior with respect to the body. And then the posterior fibers of the deltoid and the latissimus dorsi will do so as well. Now, when we look at the neurovascular bundle, again, because of how this plays out, we consider it very, very broadly. As a general note, with respect to the latissimus dorsi, it is the thoracodorsal nerve from the brachial plexus. With respect to the deltoid, it's the axillary nerve. And then with respect to the teres major, I believe it is the lower subscapular nerve, right? Then what you're thinking about with each one of those, as far as circulation is concerned, is going to be primarily with subclavian, cervical, and axillary circulation. Because you have to consider all those areas with respect to the muscles that create extension, if you just generally consider the neurovascular bundle, in that you'd want to consider the cervical region, the upper ribs especially, if not the ribs generally, you want to consider the clavicle, you want to consider the axillary region, and then you want to consider the scapula. So you'd want to consider the medial border, the lateral border, and then on the anterior side, you'd be considering the pectoral region. If you identify motion issues and deal with those, in most cases with respect to the shoulder, you're going to do a very good job of dealing with whatever mechanical interference would be occurring that would to the neurovascular bundle that would relate to the motion problems you have found. So you don't have to chase this and be overly granular because of the way that this neurovascular bundle tends to sit. Now, in other regions, you may need to be a little bit more specific, but not often. If you pay attention to the motion dysfunction that you find, you will almost always behave according to the problem at hand, as opposed to making up things and making assumptions and going and chasing those. So if we're talking about something like lumbar flexion, and you have to consider all the way from the subclavian circulation, the internal mammary or internal thoracic, till it becomes a superior epigastric, then all the way down through the abdominal region to the iliac circulation for the inferior epigastric region, you have to join all those together. Whereas if you just look at the motion problem, then you behave according to the problems that are evident and at hand, and you behave accurately, rather. So as far as areas of consideration for assessment and treatment, as we've already noted, and we will continue to note, within the shoulder region, you consider the clavicle, the cervical column, very generally speaking. So you're thinking about the levator scapula and the rhomboids in the cervical column. You're also thinking to some degree on the neurovascular bundle of the scalene muscles. You're going to think of the thoracic column, generally speaking, the trapezius and the rhomboids here. You're going to think of all borders of the scapula, so the medial border, the lateral border, which would give you access pretty quickly to teres major and the latissimus dorsi, and to some lesser degree, other rotator cuff muscles. You're going to think of the pectoral muscles, and you're going to think about the ribs. All of these things are going to be what you're checking. Now, if the specific problem that you note is a difficulty with shoulder extension, you're obviously going to work on that, but you still want to check everything else to ensure that there isn't something else that is smaller and more difficult to note to identify and deal with. So again, you always want to identify motion problems and behave according to the motion problems that you found, because usually that allows you to behave accurately to the problems at hand. As far as red flags and contraindications, this is going to be pretty redundant once again with respect to the general thoracic region. So a known tear or fracture is a clear sign to not treat, right? Especially not the area. You may be able to have some positive impact on the patient treating in other areas, but you have to be extremely cautious with that. Suspected fractures or tears are a referral to a physician for more extensive or more accurate identification of those things, so possibly imaging. And if it becomes a known fracture or tear, you don't treat that area. If you are cleared, if there is no fracture or tear, then more likely than not, this complaint is a little bit more, or a little bit less sinister rather. So there's a little bit less problems. You're more likely safe to treat that area. But if there's a suspected fracture or tear, you refer out for further investigation. If there is recent dramatic changes in cognitive function, so the head or the neck is what you would be considering here, but there could be problems with circulation into and out of the head, which would be notable through the changes in cognitive function. That is a definite don't treat. That is send out for further medical investigation, especially in an emergent way, because those drastic changes could be many things that you do not have to differentiate. You just have to know, don't treat it. Recent dramatic changes in respiration could be a pneumothorax, could be an unknown lung pathology, or it could be a heart pathology. Either way, if it is recent and dramatic, you want to stay away from that. The same thing applies. You don't have to differentiate. You just have to know if there's a recent dramatic change in respiration, which would often show as the patient being out of breath in front of you, or the patient noting that they were becoming much more out of breath with greater ease, especially when doing something like climbing stairs. So those are things you want to be very careful for. Again, the general note within the shoulder region is you're going to have to check everything anyways, and that's going to allow you to behave accurately with respect to the neurovascular bundle and the motion, because you identify the motion problem and you treat that accordingly. And if it happens to be one of the more specific motions, then go ahead and pay attention to that. But it's all off of motion assessment, and then treatment follows that.